All right, let's jump right in. Today, we're tackling a differential diagnosis that, is just so critical in endocrinology and metabolic bone disease. Osteoporosis versus osteomalacia. I mean, they both can show up with low bone density. They both can show up with fractures, but they are fundamentally different animals. And getting this right, it isn't just some academic exercise. It's absolutely essential for keeping our patients safe. So let's get into it.
This warning right here from the literature, it really sets the stage for everything we're about to talk about. Think about it. Giving a potent anti-resorptive, say a bisphosphonate, to a patient with unrecognized osteomalacia, it's not just ineffective. It can be, catastrophic. You're essentially freezing an unmineralized, soft skeleton right in its tracks. It worsens the defect and can cause a really severe clinical decline. This is exactly why we, as clinicians, have to be absolute masters of this differential.
Okay, so where do we even start with separating these two? Well, it all comes down to the basic pathophysiology. And honestly, the best way to frame this, the most powerful way to think about it, is quantity versus quality.
So this really distills the whole problem down, doesn't it? For osteoporosis, the issue is purely quantitative. You just have too little bone. The bone you do have is mineralized just fine, but the whole structure is compromised. It's porous, it's brittle. I love the analogy of an old bridge where the steel supports have just rusted away. Now flip that completely. Osteomalacia is a qualitative defect. It's a disease of soft bone. Your osteoblasts are working. They're cranking out bone matrix, but because there's not enough mineral, it just fails to harden. It's like trying to build a skyscraper with concrete that never set. The framework is there, sure, but it's got zero compressive strength. And that right there is the fundamental divide we're talking about, brittle versus soft.
All right, so we've got this physiopathology down, this idea of quantity versus quality. But how does that actually translate to the clinic? What does the patient sitting right across from you in the exam room actually look like?
And here it is, the first major fork in the diagnostic road. Osteoporosis, well, we all know it as the silent disease, right? Patients are usually totally asymptomatic until, bam, they show up with a fragility fracture. The pain is acute, it's localized, it's all about that one event. Osteomalacia, though, it's the complete opposite. It is profoundly symptomatic. You're looking for that classic triad, a diffuse, dull, aching bone pain all over, significant proximal muscle weakness, and that really characteristic waddling gait. So bottom line, if your patient is complaining about bone pain, but there's no clear acute fracture, your suspicion for osteomalacia has got to go way, way up.
Okay, so the patient's story gives us some really strong clues. But let's be honest, the biochemical workup, that is the absolute cornerstone of the diagnosis. This is where we can really efficiently and reliably pull these two conditions apart.
And this chart, this tells the whole story. Look, in a patient with straightforward primary osteoporosis, your mineral labs are going to be normal. Just normal. Serum calcium, phosphate, alk-phos, all squarely in the reference range. Yeah, sure, you might see a little ALP spike after a big fracture, but the baseline is normal. Now, contrast that with nutritional osteomalacia. The labs are screaming that something is wrong. They are characteristically abnormal. You're expecting low or low normal calcium, low phosphate, and a secondary hyperparathyroidism kicking in. But what's the one thing that stands out the most? The single most consistent, most sensitive marker? It's that significantly elevated alkaline phosphatase.
And then, of course, you have to look at the vitamin D. The difference here is just profound. Lots of patients with osteoporosis might be a bit insufficient in vitamin D, sure. But in nutritional osteomalacia, we're talking about severe, profound deficiency. A 25-hydroxy vitamin D level less than 10? I mean, that is a classic hallmark finding. Okay, now for a really important clinical pearl, a little gotcha you have to be aware of. We just said high ALP is our most reliable marker, right? Well, there's a critical exception. You have to keep the rare but vital diagnosis of hypophosphatasia in the back of your mind. It's a genetic disorder where patients look exactly like they have osteomalacia. Bone pain, weakness, even pseudofractures. But their serum ALP is paradoxically low. Missing this is a huge deal because bisphosphonates are absolutely contraindicated.
All right, let's switch gears and talk about imaging. Now, this is an area that's just full of diagnostic pitfalls. It's really easy to get led down the wrong path here.
So, let's just ask the big question, the one that affects all of us in our daily practice. Can our workhorse, the DXA scan, the tool we use all the time, can it actually tell these two apart?
And the answer is a simple and emphatic no. And here's exactly why. A DXA scan only measures one thing: bone mineral density. That's it. It is completely blind to the underlying pathology. It has no way of knowing if it's seeing a loss of well-mineralized bone, like an osteoporosis, or a normal amount of bone that's just poorly mineralized, which is what you get with osteomalacia. To the DXA, both just look like a low T-score. And get this, studies have shown that something like 57% of patients with biopsy-proven osteomalacia actually meet the criteria for osteoporosis on their DXA scan. So if you're relying on the DXA alone, you are setting yourself up for a misdiagnosis.
But here's the thing. While the DXA is limited, good old-fashioned plain radiographs can give you some powerful clues, if you know what you're looking for. With osteoporosis, you see what you'd expect: generalized osteopenia, those classic wedge fractures. With osteomalacia, the picture's different. You might see this coarsened trabecular pattern, or what we call codfish vertebrae, a much smoother biconcave shape. But the real key, the absolute pathognomonic finding, are looser zones. These little transverse radiolucencies, they are the smoking gun for osteomalacia. Now, they're only there in maybe 18% of cases, but if you see them, the diagnosis is made. Game over.
Okay, so what do you do when the picture is still a little bit murky? Well, then we have to talk about the definitive method, the gold standard itself, the bone biopsy.
So, a tetracycline-labeled transiliac bone biopsy. This gives you the absolute 100% unequivocal diagnosis. Now look, we all know it's invasive. It's rarely done in routine clinical practice. But understanding what the biopsy actually shows is what really hammers home all the core concepts we've been talking about. And right here, you can see our quantity versus quality theme playing out at the microscopic level. It's brilliant. In osteoporosis, you're looking at normal bone, there's just less of it. The trabeculae are thin, disconnected, but the osteoid seams are fine, and the tetracycline labels are crisp. They show active mineralization. But then you look at osteomalacia, and the histology is just dramatic. You see these massively widened osteoid seams. I mean, they look like thick carpets of unmineralized matrix. And the tetracycline labels? They're smudged, they're blurry, or they might be completely gone. It's telling you there's this profoundly prolonged mineralization lag time. It is a complete and total failure of mineralization.
So, we've gone from the clinic to the lab, all the way down to the microscope. Let's bring this all back home, to the most important question of all. Why does this matter so much for our patients? Why is getting this right so critical when it comes to actually treating them?
And this brings us right back, full circle, to that warning we started with. Look, the therapeutic sequence here is absolutely non-negotiable. It has to be respected. Step 1, use your labs to screen for that mineralization defect. If you even suspect osteomalacia, you move to step 2, which is you must correct the defect first. That means aggressive repletion of vitamin D, calcium, whatever is needed. And only when the labs have normalized, only when that defect is resolved, can you even think about moving to step 3 and starting an anti-resorptive. If you do it any other way, you're risking exactly that iatrogenic harm we talked about at the very beginning. So after all this, the crucial takeaway, the whole point of this explainer, it really all boils down to one simple, actionable question. The next time you have a patient in your clinic, they've got a low T-score, they've had a fragility fracture, before you instinctively write that script for an anti-resorptive, what's the one simple biochemical marker you're going to check first to make absolutely sure you've ruled out the great mimicker, osteomalacia? Because answering that question correctly, well, that's what elevates our practice. That's what makes us true experts in metabolic bone disease.